Ladies and gentlemen, distinguished guests, good morning. Welcome to the Pandemic and Epidemic Preparedness Forum in the Middle East and North Africa, PEPP MENA Forum 2025, organized by the Epidemic and Pandemic Preparedness Program at the Global Health Institute at the American University of Beirut. My name is Leia Sassin, Head of Communications at the Global Health Institute, and it's my honor to serve as your Master of Ceremony for today's event. The PEPP MENA Forum brings together experts, policymakers, and practitioners for engaging discussions, knowledge exchange, and networking, with the shared goal of strengthening epidemic and pandemic preparedness across the MENA region. To kick off the day, I am pleased to welcome Dr. Shadi Saleh, Founding Director of the Global Health Institute at AUB, to deliver the opening remarks. Dr. Saleh, the floor is yours.
Sabah al-khair, good morning everyone. As always, I will keep it very brief. The PEPP program, the EPEP program, has been a flagship program for the Global Health Institute for many years now. And the reason came from what happened after COVID-19 and the lack of preparedness that we saw in many countries in the world and the region, especially in low middle income countries. So I just came back yesterday night from Berlin, from the World Health Summit, and one of the main themes in the World Health Summit was epidemic and pandemic preparedness. And I'm not sure how much you have followed what has been happening globally in global health about epidemic and pandemic preparedness. There has been the establishment of the Pandemic Fund. Last year they passed the Pandemic Accord, where countries support one another when a pandemic happens. But all of the talk in the World Health Summit over the past 3 days was the building of national and regional capacity. So many countries in low and middle income, many low and middle income countries, although they are happy with the Pandemic Accord, Pandemic Fund, but they're not believers that if another COVID-19 happens, the high income countries will come to their aid. So it's not going to be probably as bad as COVID-19, but it's still not going to be as rosy as they think they are. So what we have to do is we have to continue to build and support national capacity, regional capacity, build our health care systems, have people who are aware and SOPs that are in place in our health system in order to support in case God unwilling something again happens. So in that context, one of the main things that we are doing today is the launch of the Certificate in Epidemic and Pandemic Preparedness, which is an online asynchronous certificate developed by global experts in the field, some of which are with us in the room and they will be presenting later. And this is our role as a Global Health Institute in terms of building local capacity, building regional capacity, and supporting our region when it comes to global health challenges. So I want to thank you all for coming, but more importantly, I want to encourage you to engage with the Epidemic and Pandemic Preparedness Program as experts, as co-learners, and also as collaborators on the work that we are doing. Thank you very much. Ya'tikum al-Fafi.
Thank you, Dr. Saleh. We will now hear from our esteemed partner, the International Development Research Center, IDRC. Please join me in welcoming Dr. Qamar Mahmoud, Senior Program Specialist at IDRC, who will share a pre-recorded message with us.
Sabah al-khair, bonjour, good morning everyone. My name is Qamar Mahmoud and I am with Canada's International Development Research Center, IDRC. Some of you must know about IDRC. I'm with the Global Health Program of IDRC. IDRC has been with has been with a mandate to support research and capacity building in lower middle income countries, and it has been in existence for over 55 years. In the Middle East and North Africa region, we've been supporting from the start of the establishment of IDRC, and quite significant amount of our funding has gone to American University of Beirut, and more recently to institutes like Global Health Institute. I am very excited about this this event, this half-day event that the GHI has organized. I apologize that I can't join you today because I had prior commitment. Nonetheless, to say that, you know, this is an important event and it is a reflection of the support that IDRC has been providing, recognizing the leadership that AUB and GHI in particular has been providing in this area of work in the region and more broadly. This Global Health Institute of the AUB, I think IDRC's Global Health Program was one of the founding members of the GHI, and we provided some initial funds, but we've been providing funds ever since. And this was one of the large grants that, you know, this event is that this project, one of the events of this project is, and there is which deals with pandemic preparedness. Now, we all know that global disease outbreaks have been heavily influenced by several factors, including globalization, urbanization, overpopulation, and then climate change, and then human-animal interfaces. This has resulted in the MENA region, for example. More recently, this has resulted in several outbreaks, disease outbreaks, such as the 2009 outbreak of influenza, then the MERS outbreak in 2012, and the more recent pandemic that we all are aware of COVID-19 pandemic. What the COVID-19 pandemic exposed was that there is fragmented, weak, and inadequately resourced health systems, not just in the region, but broadly across the world. But here we're focusing on this region as such. And this grant is particularly dealing with the aspects of pandemic preparedness and health systems preparedness from that perspective. What the pandemic exposed was some aspects related to supply chain, essential medicines, lab capacity, trained health workforce, etc. When this project came about, it was really looking at the various aspects of health systems and dealing with those in an interdisciplinary fashion. The priority areas of focus for this project have been to support reliable information systems, strengthening of the health workforce, seeding and nurturing collaborations, and also with the focus on gender inequalities. One of the aspects or the outcomes or the outputs of this project in particular has been this the certificate program, and this certificate highlights the gaps in preparedness in epidemic and pandemics, and it is designed to address not just the research aspect but also the policy, community engagement, surveillance, and health systems resilience. Now these capacities and these linkages with policy and planners reflect the importance of training and the importance of research related to preparedness aspects that are tailored to the region in particular. But it also highlights the kind of the priorities in the respect to global aspects when it comes to preparedness, pandemic preparedness, and epidemic preparedness, and to strengthen health systems. Lastly, I would say here that the importance of collaboration and knowledge sharing is very important in this project, and it's also reflected in the outputs of this support and this project in particular. And these are in terms of enhancing the workforce capacity, strengthening the analysis and integration of gender inequality, strengthening of health information systems, and also governance mechanisms, policies, and practices. I'll end here, and I know that you have an exciting program ahead of you for this half-day event. I again apologize that I couldn't join, and I really wish the organizers and the participants success in this event today. Thank you very much.
Thank you, Dr. Mahmoud. We now move to our keynote address, which will set the tone for today's discussions. It's my pleasure to welcome Dr. Gabriel Novello Sierra, Health Emergencies Program Team Lead at the World Health Organization, WHO Lebanon, to deliver his keynote speech. Dr. Sierra, you have the floor.
Good morning. As introduced before, my name is Dr. Gabriel Novello Sierra. I am the WHO Health Emergency Program Team Lead here at WHO Lebanon, originally from Mexico, but very happy to be here. So it is with on the name of Dr. Abdenasir Abubakar, who is our WHO representative. Good morning, distinguished guests, colleagues and friends. It is with great pleasure and honor to be with you today at the PEPP MENA Forum, an important gathering dedicated to advancing our shared visions and building stronger, more resilient health systems in the face of epidemics and pandemics. I would like to thank the Global Health Institute of the American University of Beirut for convening this vital discussion, for its continued commitment to strengthening epidemic and pandemic preparedness in the MENA region, to initiatives like the Certificate in Epidemic and Pandemic Preparedness. The COVID-19 pandemic reminded us that health security is only as strong as its weakest link. It revealed the deep interconnection between countries and the urgent need for systems that not only respond to crises, but anticipate and prevent them. In the post-pandemic area, we stand at a crossroad. The question is no longer whether another pandemic will come, but how well we'll be prepared when it hits. At the World Health Organization, our collective efforts are guided by a vision of global solidarity, one that translates high-level frameworks into real-world capacity, enabling every country, regardless of resources, to detect, respond to, and recover from health threats swiftly and equitably. This is especially important for the World Health Organization, as we are a member states organization which provides support to these entities. So this vision is reflected in the international health regulations, the pandemic agreement, and the preparedness and resilience for emerging threats initiatives that are global frameworks that put together the backbone of health security. However, frameworks are not enough. We truly determine success of how these global strategies are implemented and adapted at the national and subnational level. Countries in the MENA region have demonstrated remarkable progress from strengthening surveillance systems and emergency operations centers to improving regional data exchange. Yet, challenges remain, and gap in workforce capacity, coordination across borders, and sustainable investment in preparedness during the times of calm. Bridging these gaps require not just policy alignment, but people-centered capacity building, equipping health professionals, policymakers, and communities with the skills and knowledge to operationalize preparedness in real time. This is why initiatives like the Certificate in Epidemic and Pandemic Preparedness are so critical. This program, developed by our friends at the Global Health Institute, responds directly to the region's needs, strengthening competencies across surveillance, policy, ethics, communication, and community engagement. It builds the bridge between global frameworks and local realities, empowering the very individuals who transform preparedness into plans of action. It is a tangible example of what it means to localize the global health security, not through a one-size-fits-all approach, but through a contextualized training that reflects the realities, the challenges, and the strengths of the MENA region. When we invest in people, we invest in systems. And when we build solidarity at the regional level, we create resilience that extends far beyond borders. In closing, as we move forward, let us remember that preparedness is not a technical goal only. It is also a shared responsibility and a moral imperative. We must continue to strengthen partnerships across governments, academia, civil society, and international and national organizations, ensuring that no country and no community is left behind. The conversations to date, from the launch of the CEPP to the expert panels that will follow, are a step towards a common vision, a region that not only responds to crises, but leads the way in preventing them. Together, through collaboration, knowledge, and solidarity, we can build a future where preparedness is not a privilege, but a standard. I would like to end this with a personal commitment. I've been involved for the past 19 years in work, always in emergencies, and in some of the poorest countries in the world, and helping some of the poorest communities. So I think that this is an initiative that we really would like to see replicated and disseminated across all the countries in the region. Thank you very much.
Thank you, Dr. Sierra, for that insightful and inspiring address. Next, we will have an overview of the Epidemic and Pandemic Preparedness Program, EPEP, at the Global Health Institute. I am pleased to invite my colleague, Ms. Noor Zaou, Program Manager, to share details about the program and its flagship initiatives.
Good morning, everyone. Good morning, everyone. First of all, thank you so much for being here in the Pandemic Epidemic Preparedness Forum for the MENA region for 2025. I will give an overview over the Epidemic and Pandemic Preparedness Program at the Global Health Institute, AUB. First of all, the Global Health Institute, established in 2017, is the first such institute in the MENA region and among the very few in the Global South that addresses global health challenges through an interdisciplinary and contextualized approach. The Global Health Institute works through 3 divisions. So the first one is the programs. That's the research and policy division. Currently, we have 5 ongoing programs, and these are the conflict medicine, the e-Saha, that stands for digital health program, refugee and migrant health program, the epidemic and pandemic preparedness that I'm currently presenting, and the recently established CLI health program that tackles climate change and health impact. The second division that we have is the academy, and that's the capacity building. We have several initiatives under this division. Here we have representing some few, such as the online learning platform that we have. It's called the GLAD, that hosts several courses, diplomas, and certificates. Some of which we have here are, for example, the Humanitarian Leadership Diploma, a certificate in NGO management, certificate in the Epidemic and Pandemic Preparedness that we are launching today, and among others. And flagship initiatives such as the Center for Research and Education in the Ecology of War, a mobile university for health, and evaluation of capacity building programs. The third division under Global Health Institute, that's the ASSIST, the Community Service and Support Division, run through the non-governmental organization initiatives, or the NGOI. To address global health challenges, global health issues, GHI functions through partnerships at national, regional, and global scales. And we have our own support service departments, including communication, administrative services, web development, and finance. Going back to the epidemic and pandemic. So we are at constant threats and risk of pandemics. The COVID-19 pandemic was not an anomaly, rather a warning that, according to the Global Health Security Index, over 70% of the world is still underprepared for a major pandemic outbreak, where the economic cost of pandemics can reach over $1 trillion. Therefore, investment in preparedness is not an expense, rather it's a vital investment in global security and economic stability. Zooming into the Middle East and North Africa, MENA, why this region is uniquely vulnerable. So there are so many factors, but the 4 critical ones are mostly the ongoing conflict and instability in the region, which leads to weakened health systems and weakened health infrastructure, the displacement of populations, therefore limited access to care, resulting in higher outbreak risks, the health workforce exodus with the loss of professionals and healthcare workers and frontliners with limited trainings as well, and the last point, that's the unequal health capacity in the region. Therefore, this leads to variability in epidemic and pandemic preparedness across the MENA region. Hence, the Epidemic and Pandemic Preparedness Program that serves as a regional and global model for preparedness under GHI. So we have 3 major objectives. We serve as a regional and global model through informing evidence-driven policies, strengthening context-specific capacity building, and enabling high-impact research and practice. EPEP, the Epidemic and Pandemic Preparedness, has led 3 successful initiatives. The first one is titled the Epidemic and Pandemic Preparedness Gateway, that features the Preparedness Stakeholder Map and the Preparedness Collaboration Portal. The second initiative on its way is the Epidemic and Pandemic Preparedness Information Hub. And the third initiative that we are all gathered here for today is the Certificate on Epidemic and Pandemic Preparedness. The initiatives that I've just mentioned are mostly guided through the ECDC, the European CDC framework, which gives a structured outline on how to tackle preparedness during emergencies and public health outbreaks. So according to this framework, there are specific competencies and capacities for preparedness in epidemic and pandemic, and these are categorized into 5 major domains, these 100 competencies. So we have the detection and assessment domain, health services, coordination communication, the emergency risk communication, policy development, adaptation, and implementation, as well as this framework categorizes workforce as policymakers, clinicians, civil society leaders, emergency managers, public health practitioners, and risk communicators. So this is the framework that guided our initiatives. Briefly going over our initiatives, the preparedness stakeholder map that we have successfully led is an online interactive stakeholder map that allows end users to understand the identity and interlinkage of pandemic preparedness stakeholders by name, country, institution, and contact information. Up till this date, we have identified over 2,500 individuals across 22 MENA countries. The second flagship that you have is the Preparedness Collaboration Portal. It's an online portal that allows experts to identify who are the researchers that publish in this field of epidemic and pandemic preparedness, who have studies in this field. So it's a community of practice of researchers. Also, till this date, we have identified over 10,300 researchers across 22 MENA countries. The third flagship on its way is the Preparedness Information Hub. It's a resource, acts as a resource center for end users, experts, researchers, practitioners, who would like to access manuals, data sets, data visualization, reports around epidemic and pandemic. So mostly gray literature around the epidemic and pandemic in the MENA, relevant to the MENA region. These 3 tools that I just showed you are available on our GHI website, but also we have advanced a mobile application which hosts the stakeholder map, the preparedness stakeholder map, the preparedness collaboration portal, and soon the information hub. So if anyone is interested, I will leave this up to 3 seconds if you're interested to download our application. Now, going back to the certificate on epidemic and pandemic preparedness. So the certificate, as mentioned, is an evidence and needs-based online self-paced 4-course certificate on epidemic pandemic tailored to the MENA region, and it's delivered on our online learning platform called GLAD. Overall, the process for development of the certificate first started with an initial desk review of capacity building initiatives, and we identified the ECTC framework that we're going to use. We then did a training needs assessment in order to identify what are the training needs, gaps, capacities, followed by a Delphi survey. And the results of the TNA and the Delphi informed the course development. So this is the overall view of how the certificate was developed. Going into the details of the methodology, because we have our first panel with our experts who will dwell more into the course skills and competencies gained. For the methodology of the certificate development, so first the TNA survey, as I said, we used it to identify what are the training needs, gaps, barriers related to preparedness among key stakeholders in the MENA. We have identified the stakeholders through desk review and snowball sampling. We were able to reach 95 professionals from 18 MENA countries. Mentioned, the survey is guided by the ECDC framework. We used a multi-method, mixed approach, the quantitative using the Hennessy-Hicks tool and the open-ended question to address, so we asked the experts to rate the competencies based on the importance of the competency versus the ability to perform. So to rate on a scale of 1 to 7, and open-ended question related to what you think the factors, barriers related to training needs and lack in preparedness. The TNA, as mentioned, was followed by the Delphi survey. So the Delphi is to reach consensus on what are the key priority areas and key competencies that are lacking in preparedness. The Delphi survey was administered with 11 regional experts from 7 MENA countries. It underwent 2 online rounds and then a final consensus meeting to establish a final agreement on what are the key priorities, refined and we prioritize the competencies, and such, based on the results of the TNA and the Delphi, we were able to tailor an evidence-based certificate in epidemic and pandemic preparedness. So briefly, as overview on the findings of the training needs assessment, so the quantitative results showed that there are significant training gaps and needs across 4 major domains: the health services, policy, detection, and risk communication. We have here these 3 because the significant percentages shown here for the health services where 80% of competencies showed highly significant training need. In policy, 35% of competencies, detection assessment, 24%. As for the qualitative results, what they think the barriers to the lack of preparedness in the region are, mostly under these three themes: capacity training, gaps in skills and expertise, lack of education training, high staff turnover, coordination and governance, where we have political interference and leadership gaps, weak collaboration and unclear roles. And the third theme, that's the resources and logistics, staff shortages, limited supplies and infrastructure, financial constraints. So these were all identified as barriers barriers to preparedness in the region. For the Delphi, so after doing the TNA, filtering through the TNA, what are the competencies needed, the 2 rounds which established expert validation and consensus, and we resulted in competencies identified as 72 essential, 20 core, and 8 basic. As such, the certificate on epidemic and pandemic was established, and it is made of 4 courses, as we mentioned. So the first course is the detection and assessment of disease outbreaks, created by Dr. Suhakan Sharara, who's present with us today. Thank you. Where it aims to, where the learner can gain skills related to detect, assess, monitor epidemics and pandemics using epidemiology, surveillance, laboratory analysis, and risk assessment. The second course is the policy development, implementation, adaptation, developed by Dr. Atika Birri from the Ministry of Public Health, where the learners gain skills related to how to develop and adapt health policies for rapid, coordinated epidemic and pandemic preparedness. The third course is on health services preparedness, developed by Dr. Nisreen Rizq. It equips the learners with skills related to prepare and how to prepare and strengthen healthcare systems for pandemics in the MENA region, focusing on threat management, communication, coordinated responses. And the last course is the emergency risk communication, developed by Mr. Zahi Shaheen, where it equips the learners with the ability to develop leadership, coordination, strategic communication skills to manage effectively public health crisis and engage stakeholders. What makes this certificate unique is, first, it's contextualized. It's created by MENA experts for MENA professionals. It's evidence-based, built on TNA and the Delphi data. You can take the certificate anytime, anywhere. It's online, self-paced, available on our GLAD platform, and it will undergo a rigorous evaluation using the GHI ECAP framework to measure effectiveness. I will end my slide here. So the certificate is officially online. If you are interested in enrolling, or if anyone in your team is interested in enrolling, please, if you scan the QR now, you will receive a 15% discount till the end of the day by 5 p.m. This is very brief on how the certificate was developed, and now we will leave it to the experts to talk more about it. Thank you.
Thank you, Noor. We now move to our first panel discussion titled The Certificate in Epidemic and Pandemic Preparedness, CEPP, Addressing Regional Capacity Gaps. This session is moderated by my colleague, Dr. Nadine Sabra, Program Manager at the Global Health Institute at AUB. Please join me in welcoming also our esteemed panelists joining us in person, Dr. Suha Kanj, Professor of Medicine and Infectious Disease at AUB Medical Center, Lebanon, Dr. Antoine Abou Fayyad, Associate Professor, Experimental Pathology, Immunology, and Microbiology at AUB, Lebanon. Also joining us online, Dr. Atika Birri, Head of Preventive Medicine Department at the Ministry of Public Health, Lebanon, represented by Dr. Fatima Awada, a pharmacist and senior expert in public health. Also, Dr. Nisreen Rizq, Associate Professor of Clinical Medicine at AUB Medical Center, Lebanon. We look forward to hearing from you.
Thank you, Leah, and good morning, everyone, and welcome to the first panel, which is the Certificate in Epidemic and Pandemic Preparedness, Addressing Regional Capacity Gaps. So what we say, Certificate in Epidemic and Pandemic Preparedness, this is CEPP for you to get used to it during our discussion. And this panel will be divided into 3 major themes. For each theme, we have a round of questions, and each expert will be answering 1 question, and the time allocated per expert will be 4 minutes. And my colleague Noor will be monitoring time so that we keep track of today's agenda. We have with us today an excellent lineup of panelists joining in person and online. I start by introducing Dr. Soha Kanj. Dr. Soha Kanj is a professor of medicine and infectious diseases at the American University of Beirut Medical Center, where she previously led the Division on Infectious Diseases and currently chairs the Infection Control and Antimicrobial Stewardship Programs. A consulting professor at Duke University, Dr. Kanj has co-authored over 325 publications and serves as an advisor to the WHO on infection control, antimicrobial resistance, and pandemic preparedness. She is president of both the Lebanese Society of Infectious Diseases and the International Society of Antimicrobial Chemotherapy. Recently ranked among the top 2% of cited researchers globally, Dr. Kanj is widely recognized for her contributions to infectious disease research and global health security. Welcome, Dr. Soha. We now move to Dr. Antoine Abou Fayyad. Dr. Abou Fayyad was awarded PhD degree in combining chemical synthesis and biosynthesis to generate novel antibiotics from the University of St. Andrews, UK in 2014. His postdoc research work focused on discovering novel antibiotics to combat antimicrobial resistance. Dr. Antoine joined the Department of Experimental Pathology, Immunology, and Microbiology at the Faculty of Medicine at the American University of Beirut as an instructor. His research interests focus on antimicrobial resistance in gram-negative pathogens with a main focus on AMR in conflict regions under a One Health approach and the discovery of novel anti-infectives. He has over 50 publications in peer-reviewed journals and 1 patent and a book chapter. Welcome, Dr. Abou Fayyad. Joining online, we have with us Dr. Nesreen Rizq. Dr. Nesreen Rizq is Division Chief on Infectious Diseases at the AUB MC and Director of its Infectious Diseases Fellowship Training Program. A grad of AUB with advanced training at Case Western Reserve University and Yale University, Dr. Rizq has extensive experience in HIV medicine, infection control, and antimicrobial stewardship. Her work focuses on strengthening clinical preparedness and workforce capacity in infectious diseases, key pillars for epidemic and epidemic resilience in the MENA region. Unfortunately, Dr. Rizq were unable to join online, but she has already pre-recorded her answers and will be joining us hopefully at the end of the session. We have as well Dr. Atika Birri, which is represented by Dr. Fatima Awada. Dr. Atika Birri serves as the head of the Preventive Medicine and Communicable Disease Department at the Lebanese Ministry of Public Health and head of the Antimicrobial Resistance Committee. Dr. Birri is the focal person of the WHO International Health Regulation in Lebanon and a professor of emergency preparedness and response at the Public Health Doctorate Program at University of St. Joseph. Dr. Atika Birri is represented today by Dr. Fatima Awada, a pharmacist and senior expert in public health. She will speak on the areas of policy and ethics as they relate to the certificate's design. Dr. Fatima is joining with us online, and welcome, Dr. Fatima. Now we move to the first theme of this panel discussion, which is the rationale for the CEPP, responding to regional preparedness gaps. We'll start with Dr. Soha Kanj. And Dr. Soha, why was it important to create a regional certificate for epidemic and pandemic preparedness? And what gaps in the health workforce does it aim to address?
Thank you very much, Nadine. But before I answer the question, I'd really like to thank the Global Health Institute for this initiative under the leadership of Dr. Shadi Saleh. This is a tremendous work and so much needed. And I'd like to acknowledge that the part of the course that was prepared by me also was prepared by 2 people who helped tremendously in the development of the course. I'd like to acknowledge Dr. Johnny Zahour and Dr. Fatima Allah. I did write down some of the notes I'd like to express to make sure that I don't forget any important points. So I think the rationale, I think it's important to note that the COVID-19 pandemic made it painfully clear that our region really lacked a unified, prepared response. We saw countries working in isolation, health systems stretched to their limits, and major gaps in trained personnel. So the CEPP was born out of this recognition to really create a shared regional framework that builds on core competencies across the Middle East, North Africa region. Our health systems in the region are very diverse, but diseases don't respect borders. A harmonized program ensures that a nurse in Lebanon, an epidemiologist in Jordan, or a public health officer in Iraq all speak the same language of preparedness, from early detection and surveillance to outbreak investigation and communication. It also addresses deep workforce gaps, especially in 4 different areas: the field epidemiology and outbreak investigation, the laboratory diagnostics and surveillance integration, but also the risk communication, community engagement, and the One Health coordination. But also the infection prevention, the antimicrobial stewardship, and the logistic management. So finally, the CEPP really provides a very structured pathway for capacity building in countries affected by conflict and fragility, such as ours, sadly, where human resources are often very destroyed and lost, yet the need for skilled professionals is greatest. Thank you, Nadine.
Thank you, Dr. Saha. Dr. Antoine, we talked with Dr. Saha about the needs and the gaps, but what key challenges do labs face in outbreak detection, and how can programs like the CEPP help bridge the gap between labs, healthcare providers, and communities for faster and more coordinated response?
First of all, thank you for the invitation and brilliant work, Dr. Saleh, as usual. Usually in outbreaks, especially in LMICs or in our region and the Afro region, labs are always the underlooked part. We focus a lot more on the field, we focus a lot more on the hospitals, we focus on the nurses. We always disregard the lab. However, COVID came along and changed this approach, and we could see it quite well. Ourselves, for instance, here at AUB, we struggled at the start. We are a WHO collaborating center for reference and research on bacterial pathogens, and when we started, we don't only serve Lebanon, we don't only serve AUB, we serve globally. It's under WHO umbrella. And when you start helping and serving, you notice the big gaps, where do they lie? And one of the most important things that CEPP could address is the communication. Always communication is lacking, whether it's between the field and the lab, or the lab and the surveillance, or the lab and the government. And this is something that CEPP could definitely help. Also, it could help the policymakers always remember that there is a lab they need to support, because let's face it, if there is no lab, there is no diagnosis for any infection. You cannot just base your diagnosis on clinical symptoms. You need the support of the lab. So the pillar that leads an outbreak investigation needs to have very good communication skills back and forth from one side. From the other side, if they need support, whether be it consumables, which is a bottleneck in our region, and again, COVID changed this. So imagine now with the work that WHO has done and we have been supporting on, we have sequencing technologies in Somalia, in Sudan, in Yemen, and they have managed to use them if they are given the right trainings. So giving training specifically to the lab from one side, and giving training to the lab in collaboration with whoever is around them would be the two things that CEPP would help. Thank you.
Thank you, Dr. Abu Fayyad. We now move to Dr. Fatima Awada. Dr. Fatima, during health crises, decisions must often be made quickly and under pressure. Why is it essential to integrate training on policy and ethics, and how does the CEPP prepare professionals in this regard?
Good morning, all. First of all, I want to say that I'm glad being with you today, representing Dr. Atika Birdir. To answer your question, during health crisis, as you said, decisions must be taken rapidly. Yet these decisions carry profound ethical and policy consequences. Integrating training on policy and ethics is therefore essential to ensure that the responses remain evidence-based, equitable, and accountable. This step course prepares the professionals by providing structured frameworks and case-based learning. This strengthens their ability to navigate complex dilemmas while upholding ethical and policy standards. Thank you.
Thank you, Dr. Awada. And given that Dr. Nasreen couldn't make it online, she has pre-recorded her answer and she'll be answering this question. From your experience, what competencies do you see as most lacking among frontline healthcare workers in the MENA, and how does the CEPP help address these?
Frontline workers in our region are dedicated but often lack structured training in outbreak response, infection prevention, and data use. COVID-19 exposed critical gaps in this regard, such as triage coordination, rational antimicrobial use, risk communication, and teamwork across sectors. CEPP helps fill these gaps by providing competency-based and regionally relevant modules by using case studies and simulation exercises that mirror local realities, promoting cross-disciplinary collaboration between nurses, clinicians, public health professionals, and policymakers learning together. The result is a confident, better connected workforce ready to respond quickly and coherently to crises.
Thanks, Dr. Nasreen. We now move to the second theme of this panel, which is designing courses for critical capacity areas. Dr. Saha, back to you. How does the CEPP equip learners to adapt and apply global surveillance and assessment frameworks effectively in the MENA region and its context?
Yeah, thank you, Nadine. This is a very important question, and I think CEPP acts really as a bridge between global standards and local realities. Learners study frameworks as the WHO International Health Regulation, IHR 2005, for example, the One Health approach, global early warning systems, but the key, as Noor very eloquently mentioned in her presentation, is contextualization. Through the course modules, which are detection, assessment, risk communication, outbreak investigation, and environmental monitoring, participants can learn how to translate these frameworks into feasible actions within fragile or resource-limited settings. And I'll give a few examples here. They practice conducting risk assessments, for example, when data are incomplete or fragmented, which is sadly a very frequent occurrence in our region. They learn to adapt surveillance tools to context affected by conflict or population displacement, also something we experience a lot in our region. And they see how regional collaboration by sharing data across borders, strengthening laboratories, and building trust can really amplify the impact of global frameworks. So in a sense, I think when we think about CEPP, CEPP is meant to empower professionals not only to understand the international guidelines, but also to operationalize them, aligning global standards with the strength and constraints of the MENA health systems. Thank you.
Thank you, Dr. Saha. Indeed, learning frameworks are so foundational. Dr. Antoine, how does the CEPP equip participants with practical skills to strengthen diagnostic and lab surveillance capacities and ensure effective collaboration between lab, clinical, and community teams during emergencies?
Right, so again, communication using the right technique or the right words to communicate, because, you know, in the lab, we sometimes sit in our own bubble. We go very technical in what we do, and then you have to go out and talk to somebody who's in the public with lay language, and you would start using words that nobody will understand. So using proper communication techniques and using the right simple version of what tests we did, what results we got, would be one thing that the certificate helps in. Additionally, understanding which diseases are, or what tests would you do for what diseases. Take, for instance, the difference between COVID and cholera. In COVID, you test and trace, right? One of us has COVID in this room. The next thing you would do is you test everyone. With cholera, you don't do this. With cholera, you declare an outbreak in region 1, you stop testing, you just monitor. You test very limited number of samples per week, and you move on to region 2, and then region 3, and then region 4. And these are the things that, for example, we passed through in Lebanon. In 2022, we had a cholera outbreak that, how long haven't you seen cholera for in Lebanon before? Before I was born. So the idea was, it was new for all of us, and we didn't really know what to do. Our lab did more than 20,000 cultures for cholera testing for the Ministry of Health, which turned out to be useless. All what you had to do was declare an outbreak in the first region, you move on to the next region, and these are things that the certificate could help as well, is directing laboratory personnel what to test, because it doesn't only direct the laboratory personnel, it will also make the people in the field understand that the lab doesn't test every single sample you send them. The lab will test what needs to be done. This comes back to holding resources together, keeping consumables at best, and keeping the lab staff sanity to actually be able to last in an outbreak, because outbreaks are not 5 days, 6 days, 10 days, and then they stop. And we've seen with COVID how long it was. I do remember some of the photos I used to see of our colleagues in the hospital, what they used to pass through. Cholera was an outbreak which was 4 or 5 months, and in Lebanon, the cholera was controlled very quickly, but in other countries you have cholera outbreaks that lasts 8, 9, 10 months. So all these outbreaks, you need the energy to keep running alongside, because it's a race. It's either you beat the outbreak or the outbreak will outrun you. So these are things that the certificate would definitely help with.
Thank you, Dr. Antoine. Dr. Fatima, how does the CEPP strengthen skills in policy, ethics, and evidence-based decision-making for health professionals?
Okay. CEPP strengthens these skills by combining the theoretical foundation with the practical applications. This helps enable the professionals to critically assess the evidence and translate it into sound policy decision through interactive modules found in the CEPP and real-world case studies mentioned that we lived. The participants refined their ability to integrate the ethical reasoning with the evidence-based approaches, which ensures that the health policies will remain both scientifically rigorous and socially responsible. Thank you.
Thank you, Dr. Awada. We'll now watch a video together for Dr. Nisreen answering the following question. What approach in the CEPP prepare healthcare workers to ensure continuity of care and manage surge capacity during health emergencies?
Emergencies disrupt health systems. Essential care stops when all attention shifts to crisis response. CEPP trains learners to plan and manage surge capacity, anticipate needs for staff, oxygen, beds, for example. Second, apply triage and infection control principles under stress. Third, balance emergency response with continuity of chronic and essential care. Through exercises, participants practice prioritizing limited resources and maintaining safety, especially in low-resource or conflict-affected settings.
Thanks to Dr. Nisreen. And now we move to the third part of this panel discussion, which is contextualization for the MENA region and fostering regional collaboration. Dr. Suha, which learning methods, such as simulations, case studies, and role plays, have proven most effective for preparing professionals for emergencies and fragile health systems, and how does the CEPP incorporate them?
Yes, also a very important question. Thank you, Nadine. So I think experience has shown that really professionals learn best when they practice what they will face. And I think with that in mind, this is how the CEPP was created. It emphasizes experiential learning, simulations, there are case studies, role plays drawn directly from examples from the region. And that is what makes this certificate very important for people from the region. So for example, simulations mirror real-time outbreak scenarios, allowing participants to make decisions very promptly under pressure, but also, as Dr. Abu Fayyad was mentioning, how to allocate resources, coordinate across various sectors between the people on the ground and the laboratory is just one example. Case studies, in the CEPP, there was use of examples such as cholera in conflict zones, which also was alluded to earlier with the cholera outbreak we had in Lebanon, for example, cholera outbreaks in Sudan that continue to be a major problem, or of course the famous COVID-19 responses that we've had to deal with all over the region, but also it was even worse in refugee camps, which really ground theory in regional experience. Role plays, for example, they help developing the soft skills, which are very essential in crisis leadership, communicating. Again, the issue of communication, which is very important. How do you communicate with communities? How do you manage uncertainty? And the COVID-19 was a perfect example of that. And negotiating between ministries, and I'm happy to have Dr. Fatima speaking on behalf of Dr. Berry here, and the humanitarian actors. And we had many, many NGOs as an example. How did they deal with helping us manage the COVID-19 pandemic, for example? But also in this certificate, there was an integration of examples from history. For example, reflecting on very old pandemics and what went wrong during these pandemics, and what did we learn from these mismanaged pandemics. And the aim is that those mistakes are not repeated in any, God forbid, future pandemics. So the course really invites learners to adapt lessons from well-resourced contexts. The GCC, the Gulf Cooperation Council countries, how did they deal with COVID-19 versus other countries in the region is one example. So we want to really try to learn from these two settings where resources are very limited, such as here, such as Syria, such as Palestine, but where the human capital and resilience are strong, and this is what we keep priding ourselves to say, we're resilient people. So the blended CEPP, this is an interactive approach that ensures that by the end of all the courses of the certificates, participants really are not only knowledgeable, but also they are ready to act, to lead, to adapt when the next emergency strikes.
Thank you so much, Dr. Suha. Over to you, Dr. Antoine. Well, this is a long question. How does CEPP integrate scientific and community-level approach, such as lab-based surveillance, risk communication, and digital learning tools to foster collaboration, knowledge sharing, and trust building across the MENA? And what key lessons from this process can guide future regional preparedness initiatives?
So one of the things that Noor showed on the slides, the community of practice, this is a brilliant idea. So I work with the cholera team in WHO Geneva, and we've been building a community practice for cholera, and it's been working really nicely. That's one thing. The other thing with the certificate itself, with all what we've listed before, touching base also on data sharing. And data sharing, especially in our region, is a huge bottleneck. And it became worse with COVID as well. Why did it become worse with COVID? Because we start at the beginning of COVID, the variants were called based on countries or cities. And then the shaming started with that. And this caused countries to stop reporting at some point. And during the COVID pandemic, we've reached a point where genomics to be used was technically almost used on every single country on the planet, almost. Imagine you've had countries like Afghanistan and Somalia and Sudan, they sequenced their own samples and they shared their own data. But then you look at it from the other side, some countries decided to stop sharing data because of the shaming part. And when you talk about other diseases of epidemic or pandemic concern like cholera or typhoid outbreaks, like the one in Pakistan at the moment, these also are outbreaks where countries refuse to share data because of the shaming and the economic repercussions that it can have on the country. So highlighting to whoever is taking the certificate the importance of not only communicating within country, but also communicating with WHO, with the neighboring countries, in order to get the proper support they need, because sometimes the support can be just next door. You don't need support elsewhere. The same way we've supported Syria several times, the same way we've supported Iraq several times. The support can be right next door. So using the right communication skills, data sharing, and abiding by the data sharing policies. Because one of the things with the WHO mandate is sharing data, sharing information about outbreaks and diseases is really important. And this is something that any member state within the WHO agrees on. But we don't always apply it. That's one thing. The other thing is the ability to detect diseases from one side, and the ability to apply the right test to the right sample also helps quite a lot, because you minimize wasted material and wasted tests. Thank you.
Thank you. Thank you, Dr. Abu Fayyad, and for walking us through real-life examples. We now move to Dr. Fatima Awada. Dr. Fatima, how does the CEPP help professionals translate global preparedness frameworks into effective actionable strategies within conflict-affected areas?
Okay, CEPP plays a role in connecting, as Dr. Saab previously said, it's a bridge between the global preparedness frameworks with the real-world application. By adapting standards, international standards such as the IHR and WHO frameworks to the unique challenges of the low resource systems, this program equips professionals to analyze local contexts, identify the system weaknesses, and design practical evidence-based interventions aligned, as I said, with the national priorities and capacities through immersive learning methods such as the policy simulations, the scenario analysis, and the system thinking exercises found in the program. Participants strengthen their ability to coordinate across sectors, manage limited resources, and implement effective preparedness measures. This hands-on approach fosters sustainability, local-driven strategies that enhance national resilience, ensure strong alignment with the global health frameworks like the IHR and WHO guidelines, as I said previously, and build long-term capacity for epidemic and pandemic response. Thank you.
Thank you, Dr. Awada. And now we move to the last question. How does CEPP prepare professionals to work effectively in resource-limited settings, coordinate across teams, and manage outbreaks in fragile health systems? And this question will be answered by Dr. Nasreen Reza through a pre-recorded video.
PEPP is designed for fragile, resource-limited environments common in our region. And it focuses on adaptive leadership and coordination when resources and protocols are inconsistent, with practical infection control strategies using locally available tools, and by building a regional peer network to strengthen mutual support and knowledge sharing, with the aim of moving from reactive crisis management to a culture of proactive, sustained preparedness.
So this marks the end of our discussion. Thanks to our panelists who were with us today in person and who joined us online as well. We can conclude the session by saying that the Certificate in Epidemic and Pandemic Preparedness was developed to fill critical gaps in workforce skills, especially in community communication, ethics, and surveillance. Practical hands-on learning paired with digital tools and with regional lens is essential. And of course, the context matters because the fragile systems require resilient design, local ownership, and realistic tools. Now we open the floor for discussion and for questions from our attendees. Noor, do you have time?
Yes.
How many questions can we take?
So we have a question from Dr. Marha from IHR Iraq. All the course is going to be self-learning, or will we have interactive sessions? What about SIMX?
What is
Simulation exercise.
You're in a better position to answer this because you're
Yes.
familiar with the content of all the 4 courses.
So Dr. Marha, I will be answering this question. So yes, the courses, all the courses and all the, as we have mentioned, the certificate actually, it's a self-learning online. And yes, there are several interactive sessions and activities within the courses and within the modules. So there are some interactive sessions, and for the simulation exercises are mostly linked to on-spot work, linking to different activities across different modules as well. So yes, self-learning, yes, there are many interactive key checks and quizzes, even the quizzes are interactive by themselves, and it will equip the learners to understand how, when different situations happen and when examples take place, how to react.
We'll now take another question.
I can answer questions.
Yeah, of course.
The target audience. I can speak. I think my voice is already loud. Hi. My question is about the target audience.
Did you hear me? Did you hear me?
Hi, Dr. Bassam. Yes, now we can hear you, but okay, so please go ahead, ask your question, Dr. Bassam.
I am an outlier. I am a general surgeon invited to this meeting. Your topic is epidemic pandemic. If I understand good, pandemic is on a global level, international level. Epidemic is on a regional level or country level. What about endemic? Endemic, I am working in accreditation of hospital accreditation. I am endemic. What about endemic? What I understand from endemic, perhaps you have another definition. 2 examples of an endemic in the hospital is the first food infections from food coming from the kitchen. The second, surgical patient infections from the operating room. Thank you for the clarification.
I can answer this question. Thank you, Dr. Ghazi, and we're very happy to have a surgeon among us, and we have a gastroenterologist. That's really impressive to see people from outside the field of public health and infectious disease and nursing, etc., join the course. So endemic is infection that you are encountering all the time. So one example is brucella in Lebanon is endemic. Tuberculosis in India is endemic. However, if you have a surgical site infection with a Pseudomonas aeruginosa, let's say, in a wound, in 2 or 3 different patients who had surgery around the same time, then we call this an outbreak that requires investigation. So as you pointed out, the definition of epidemic and pandemic, you got it right. I think endemic is the diseases or infectious diseases that are common in the setting, in the country, in the city where you practice, and you see them all the time. But again, depending, like if I get a single case of poliomyelitis in Lebanon, I call this epidemic, right? Because even a single case of polio becomes epidemic. Did I answer your question right? Is this what's meant? Okay.
So I'm Miriam Levghale. We're an international NGO for projects in the Middle East. We're based in Holland. The reason why we're here today is because we're working on a project about preparedness, but for all sorts of responses. My question is about the target audience. Can anyone actually attend the 4 courses? I mean, for me, I could attend the 3rd and the 4th, but the first and 2, I'm not sure about it. Just asking about the target audience.
So the target...
Thank you.
I will, if you want to add anything, Dr. Saha, please feel free. So the target audience for this certificate are mostly anyone is allowed to take the certificate, of course, but the targets are the healthcare workers, professionals, civil society leaders, policymakers, public health practitioners, and experts and specialists. So, but the certificate is available online to anyone who is interested in taking the course, of course. I don't know if Dr. Soha Kenj, you would like to add something?
Yeah, no, I fully agree. I think also, what we've learned from COVID-19 is a lot of people from outside the group of public health workers were very heavily involved in dealing with the COVID-19 pandemic. So, NGOs, various societies, because It depends on the nature of the pandemic, and you can think of so many people who can be involved outside the classic definition of public health worker or healthcare providers. So,
we have a question online from Dr. Marha Kamuna.
Yes, thank you very much, Dr. Noor, and thank you for all of you. I'm asking about if there is a grant going to be for the countries, especially if we are thinking of having several participants, let's say more than 20 participants from the same country, which are working in the public health emergency management section, and also focal point from different governorates as well. And also I have another question regarding the communication between the AUB and Ministry of Health in Iraq. If it is possible to be that communication going through WHO country office in Iraq to facilitate the process, and also to continue the collaboration, it will be easier for us. Thank you.
Thank you, Dr. Marha, for these two questions. So for the first part, I think you were addressing a grant as in like scholarships or specific offers for the certificate, right? If I'm not mistaken. So for the...
yes, right.
All right. So here at GHI AUB, under our academy, we do provide services for institutions. If you have for example, from the MOH Iraq, you have team members who are interested in enrolling in the certificate, of course, we provide the special offers and promotions for institutions. Now, for the second part of your question related to that, I will probably allow Dr. Gabriel, if you might be interested in answering Dr. Marha's question.
Communication from the Ministry of Health, WHO, to go also to Iraq.
Thank you. As it was explained before, there is the national authority, the National Ministry of Health, has an IHR focal point. The World Health Organization acts as the secretariat and the keeper of the international health regulations. So first, the decision needs to come from the National Health Authority to through the IHR focal point, communicated to WHO. Then WHO will communicate that at regional and global levels, because there is an obligation under international health regulations to inform any neighboring countries of a potential spread of a disease. But like I said, the initiative comes from the health authority of the country. If WHO does not receive the formal communication from the IHR focal point for the ministry, we cannot pass on the information. Also, communicating this information to WHO does not negate the point that the health authority of that country should also communicate bilaterally to neighboring countries and inform them, especially in shared border crosser points and so on, of the potential disease that might spread through international borders. So usually that is the, but once the information reaches WHO, we will trigger the communication both at regional and global levels to make sure the information is disseminated. And also, as Dr. Antoine was mentioning before, if at any point the country lacks the capacity for laboratory confirmation, WHO can facilitate to WHO collaborating centers around the world to make sure that that aspect of the investigation and the confirmation is done, but we can only do so once there has been a formal communication from the HR department.
Thank you.
Dr. Marha, this is Shadi Saleh from GHI. We support your proposed idea on having the MOH Iraq communicate with WHO Iraq to see how staff members within the ministry can also benefit from the certificate as well. So We support that initiative that you have proposed. Please let the group know on how we can facilitate that process. Thank you.
Thank you very much. Thank you.
I see no more questions. And we have one more question? Okay.
Hi, so this is Dr. Fatima Msheikh. I'm a medical education faculty member from the Faculty of Medicine at the American University of Beirut. And I really appreciate how this program talks about preparing residents or physicians or nurses or different healthcare professionals to deal with the temporal pressure of crisis and what we refer to as improvisation, and as well as with dealing with limited resources, what Dr. Antoine talked about. And this is what we refer to as bricolage, which they have to come hand in hand together. But we all know that in times of crisis, improvisation is not individual. It has to be collective among different team members. And often those team members, they have to deal with the challenges of making decisions in real time and thinking on their feet within hierarchical structures which demand seniors to approve what they need to do. So I'm really curious, how does this degree or a diploma prepare those healthcare professionals to deal with those hierarchical structures when they have to improvise collectively and not individually within the fragmented infrastructures that they have to work within? Thank you.
So I think Noor is in a better position to answer because she has access to the full content of the 4 courses.
So how does this certificate equip healthcare workers to deal with the hierarchy in different settings? So as you have seen throughout the certificate is that you have courses and trainings dedicated to detection and assessment, training dedicated to health services and hospitals and health management, dedicated to policies and dedicated to communication. So the skills that you are acquiring from these different 4 major overarching domains or overarching themes, also the practical skills. So when we say, and this is in the previous question when Dr. Marha was asking, are there interactive? And we said that yes, there are interactive because there are case studies and interactive case studies. For example, if COVID or let's say a disease X hits and do you go into lockdown? What do you do? What are the strategies that need to be done? And part of these case studies also address what the staff should do, or how does the reporting happen between the staff, whether it's like if it's in a hospital case or if it is in a community case. So there are skills that are being delivered through these courses, through these different modules and interactive sessions that equip the learner to understand how the way I should address the communication needs to flow, how the message needs to flow from, let's say, point A to point Z in order to have a good and manage an effective response to whenever, let's say, a disease happens or so.
Yeah, and if, Dr. Msheikh, so if I can add to that, I think, we've learned during the COVID-19 pandemic, obviously decisions can sometimes be made wrongly by leadership of institutions, of organizations. But the more knowledgeable you make your people who are being consulted to make the major decision, so you build a group of people who become so knowledgeable, so comfortable for how to plan for this, whatever new pandemic you have. I think the COVID-19, at least if I give the example of AUB, it really taught us that the more you consult with those people who have developed the knowledge and the how to do things, the more decisions are made in the right direction rather than being imposed through a hierarchy of I'm the boss and I make decisions based on poor knowledge sometimes. So I think you just build the knowledge within the organization and you surround yourself with the people who have acquired the knowledge for how to act during pandemic. And maybe teach you how to negotiate.
Just to add one more point as well. Pandemic response or outbreak response is a mindset. You need certain tools, and those tools needs to be activated With a switch, I'm talking from a lab perspective, from a surveillance point of view. With a switch, you turn from routine work to response. The certificate has the elements to put these tools somewhere in your belongings, that your response would be, your preparedness would be, whenever you need those tools, you get them and you can start. And this is how, in my experience, response to outbreaks has been, not only in Lebanon, every mission we go to, every outbreak we respond to, it's the same thing. It's a toolkit that turns on with a switch of a button. That's it. And this is what's really good about the certificate. It triggers those tools that you need to have them ready. And I'm talking about the course that Dr. Kench prepared. I don't know about the other three, but the first one has that advantage. Thank you.
I think one last question.
Yeah, this is Fadi Daniel. I'm an associate professor of gastroenterology at AUB, and this is to answer why a gastroenterologist is here. I'm representing the Lebanese Order of Physician President with full support. After hearing all of this, I want to end by, it brings to my memory a quote about if I had a 1 hour time to chop a tree, I would spend 50 minutes sharpening my axe. I believe that's to complement what Tony said, that this is what's all about. It's having the cookbook ready in case, having the axe sharpened in case you have to cut the tree. You know, hoping we don't like to cut any cutting tree, of course, but we are ecologically sensitive, but this is, thank you. Good luck.
Thank you all for your participation and contributions, and thanks again to our experts for your effort. This marks the end of this session, and over to you, Leah.
Thank you. We will now take a short 10-minute coffee break. Please feel free to step out and network with colleagues. We will reconvene shortly for panel 2. Discussion titled Pandemic and Epidemic Preparedness Post-COVID, Exploring Path to Sustainable Global Health Security. This session is moderated by Dr. Ruba Ziadeh, Associate Researcher at the National Center for Natural Hazards and Early Warning, Lebanon. Dr. Ziadeh specializes in anticipatory action, climate change adaptation, and multi-hazard risk assessment. Her work focuses on integrating geospatial analysis and climate data to develop early warning systems for hazards such as heat waves, floods, winter storms, and forest fires. She has collaborated with national and international partners to advance forecast-based financing and resilience building initiatives across the MENA region. Dr. Ziadeh, the floor is yours. Please join me also in welcoming our esteemed panelists joining us here today. Dr. Gabriel Novelo Sierra, Health Emergencies Program Team Lead at the WHO Lebanon. Mr. Sherbel Elia, Regional Senior Officer for Anticipatory Actions at IFRC Lebanon. And joining us online, we have Dr. Nada Ghosn, Head of the Epidemiological Surveillance Program at the Ministry of Public Health, Lebanon. Her Excellency, Dr. Farida Al-Hassani, Deputy CEO at Global Institute for Disease Elimination and Chair at WHO Pandemic Influenza Preparedness Advisory Group in the United Arab Emirates. Dr. Kamran Khan, Founder and CEO at Blue Dot and Professor at University of Toronto, Canada. Dr. Rania Atiya, Public Health Expert, Migration Health Division at the International Organization for Migration, IOM MENA region in Egypt. We are excited to hear your insights. Please go ahead.
Good afternoon, everyone. Welcome to panel 2 on the PEPP MENA Forum 2025, Pandemic Epidemic Preparedness Post-COVID, Exploring Paths to Sustainable Global Health Security, which is part of the PEPP MENA Forum 2025. The COVID-19 pandemic fundamentally shaped how we think about preparedness, exposing all our vulnerabilities, but also driving innovation, collaboration, and political momentum. With the World Health Organization 2025 Pandemic Agreement setting new commitments, the challenge before us is not just reacting to crises, but sustaining preparedness as a long-term investment in resilience. In this discussion, we'll look at how our region is rethinking preparedness through technology, governance, and cross-sectoral collaboration to build a more anticipatory and sustainable approach to epidemic and pandemic threats and reach regional and global health security through three main pillars. One is AI, surveillance and early warning. Two is governance and preparedness frameworks. And three is cross-sectoral and regional collaboration. Today, we are honored and lucky to have with us leading experts who each represent a critical piece of this ecosystem. Joining us online from the UAE, Her Excellency Dr. Farida Al-Husani, Deputy CEO of the Global Institute for Disease Elimination, GLIDE, and Chair of WHO's Pandemic Influenza Preparedness Framework Advisory Group. Dr. Al-Husani played a key role in the UAE's COVID-19 response and has led public health and infectious disease initiatives, including the Abu Dhabi Public Health Center. She is an advocate for innovation and AI in public health, holding advanced degrees from Johns Hopkins University and UAE National Defense College. Also joining us virtually from Canada is Dr. Kamran Khan, Professor of Medicine and Public Health at the University of Toronto and founder of Blue Dot, a global epidemic intelligence company. Dr. Khan has over 2 decades of experience in global epidemic research and outbreak prediction, translating scientific knowledge into actionable public health strategies. Joining us from Egypt, Dr. Rania Atiya, public health and emergencies expert with over 20 years of experience in epidemiology, preparedness, and health system resilience. Dr. Atiya currently supports IOM's Migration Health Division in MENA, previously held roles in WHO EMRO and Egypt's Ministry of Health, and focuses on equitable access to emergency health services. From Lebanon, but also online, Dr. Nada Ghusn, head of the epidemiological surveillance program at the Ministry of Public Health since the year 2000. Dr. Ghusn oversees communicable disease surveillance, outbreak investigation, and capacity building. She also directs the Lebanon Field Epidemiology Training Program and lectures at the Lebanese University Faculty of Public Health. Here in person with us, we have Dr. Gabriel Novello Sierra, WHO Health Emergency Team Lead in Lebanon, with 16 years of experience in emergency response and coordination across all WHO regions. Dr. Novello Sierra trained in Mexico and the UK, with a strong focus on improving health conditions in emergency-affected populations. And last but not least, Mr. Sharbil Elia, Regional Senior Officer for Anticipatory Action at IFRC. Mr. Elia supports early action and preparedness frameworks in the MENA region. His work aims to reduce the impact of forecasted hazards through proactive interventions, integrating communities and humanitarian organizations in timely crises responses. Thank you all for being here. So let's begin with our first theme. So pillar 1, which is artificial intelligence and early warning. To start, I'd like to address Mr. Kamran Khan. Dr. Khan, how can AI-driven epidemic intelligence tools like Blue Dot be integrated into low-resource public health systems to improve early warning and response?
Well, first of all, I'm going to say good morning from Toronto in Canada. Can you hear me okay?
Yes.
Okay, perfect. And thank you for the invitation to be part of this discussion today. Let me maybe break the question down that you've posed. I think one aspect is around integration into other systems, and the other is adoption by low resource in low resource settings. So I'd like to maybe just break the question into those two components, because I think they're both related but also distinct. So I'll start out with the issue of integration, and I think we all know that epidemic and pandemic preparedness is not a public health issue alone, or a public health sector issue alone. Ultimately, this is a whole of society responsibility and a challenge. And so I think one of the things I've certainly learned in my role at Blue Dot is that it's essential that innovations in epidemic surveillance and intelligence are highly integratable into a wide range of sectors, not just the public sector, but the private sector, the academic sector, the healthcare sector, NGOs, and nonprofits. And I think this is something that, you know, we learned firsthand during the COVID-19 pandemic when we started working with clients who were not just in the public health sector. I mean, I'd say this is where we started as an organization. Almost all of our initial clients were in the public health sector. But during the pandemic, we quickly learned as other sectors started to come on board that everyone had a slightly and sometimes maybe not so slightly different perspective on the problem. We could see that public health agencies needed to conduct global horizon scanning of infectious disease threats and conduct rapid risk assessments of you know, what kind of threat this posed to their population. Similarly, we would see multinational businesses that had locations around the world. They also needed to conduct global horizon scanning, and they needed to assess what the risks might be to, you know, their people, their supply chains, their operations. Pharmaceutical and life sciences companies that make vaccines, therapeutics, diagnostics, and many other medical countermeasures, they needed this intelligence to understand where those countermeasures needed to be deployed and where there were resilient supply chains in place. We found defense organizations were ultimately interested in protecting the forces that were deployed in different parts of the world. And the security community was really looking at this through the lens of, you know, identifying unusual or unexpected events that might indicate a deliberate act. We also learned during this time that our clients were using a wide range of different types of business intelligence applications. Now, when we started as an organization, we had a software solution that we got all of our clients to come into to extract whatever data they needed. But quickly, as we had a wide range of roles across different sectors, it became clear that they all had different workflows. And so one of the decisions that we made around integration, coming back to that point, is that we transitioned away from forcing people to come into our workflow, into our software application, and we flipped it around and we started to use what are called APIs, just sort of a technical term, to bring data and intelligence and insights into the workflows, into the applications that our clients were using every single day and were familiar with. This is where their eyes and ears were focused all the time. So I think this was one of those critical learnings about how to integrate in a way that made adoption usable, actionable, and meaningful on a regular basis. And maybe I'll just very briefly say there was sort of three key areas that everyone had in common, regardless of where, which sector they were coming from. And then I'll speak to the issue of low resource settings. But I think the first area was, you know, regardless of sector, everyone wanted to be aware of biological threats anywhere in the world at the earliest stages. So really this was the foundation of some of the surveillance systems that we developed using AI to augment our capabilities. And so we've been using AI and language models large before ChatGPT and large language models came onto the scene to increase the breadth and depth and the timeliness of our surveillance activities across many different sectors, the animal health sector, human health, environmental surveillance, and so forth. The second thing that was in common was everyone needed to do rapid risk assessments to understand what risk does that particular outbreak pose to me in my location, and how do I make a decision without overreacting, which comes with costs and consequences, or underreacting, which also comes with risks. And then finally, they ultimately needed to communicate these insights to a wide range of decision makers and stakeholders. And you know, this is an area now in the era of generative AI where we've been actually using machine intelligence to be able to actually help us augment communications to a wide range of personas in different audiences. So that was basically how we tackled the issue of integration. And maybe just, I'll take about a moment or so here to just talk a little bit about the issue of low resource settings and how we've done this. This has been an interesting and probably one of the most significant challenges that we have faced and we continue to face. We've had the pleasure of working in the ASEAN region, the Association of Southeast Asian Nations, now for over 10 years. And I think you'll know there's a wide range of countries from Singapore, which is maybe the most highly industrialized, to places like Laos and Myanmar and Cambodia and so forth, which are far less developed and industrialized. In this setting, we've had sponsors like Global Affairs Canada supporting some of the work that we've done in that region, and really have taken an approach to co-solution on problems with our partners there, because really it engages everyone and everyone is highly invested in the outcome. We have a shared understanding of the problems we're tackling, a shared understanding of what success looks like, and it's all built on a foundation of trust. So I think maybe just to summarize, I would say integration has been a critical issue to make sure that data from surveillance and other forms of intelligence are usable, actionable, and brought into the workflows of our clients every single day. And then the second, on the resource limited side of things, that has and continues to be a challenge, but we've had the benefit of having sponsors who understand that detecting threats early in resource limited environments ultimately gives us a better opportunity to control those outbreaks at their origin, rather than having to deal with them as they may disseminate and spread to other parts of the world. So I'll pause there just to
Thank you so much.
Conclude my remarks to your question.
Thank you so much, Dr. Khan. What you shared on global intelligence tools ties directly to how countries actually make this work on the ground. This is when we go directly to Dr. Nada Ghassan, from national perspective, how is the Ministry of Health in Lebanon leveraging digital tools or AI to strengthen early detection and response? That's one. And what are the main challenges for sustaining these systems in Lebanon? So waiting for Dr. Nada to come back online. We'll move to pillar 2. Okay, which is mainly is going to discuss governance, policy, and preparedness frameworks. And here we are going to start with Dr. Al-Husani. Dr. Al-Husani, the UAE has been a regional model in institutionalizing preparedness through frameworks like your National Influenza Preparedness Plan. What lessons can other countries draw from your experience embedding preparedness as a governance priority?
Thank you. First, I would like to start by thanking Global Health Institute and American University of Beirut for inviting me to participate with the esteemed guests in the panel. I hope that I could attend in person, hopefully in the future, but I couldn't miss this opportunity and be with you guys in this important discussion. Starting with institutionalizing preparedness, I remember when I joined first public health, I started my career around a global pandemic time where we had influenza 2009 pandemic that hit the world with many challenges. And I was really struggling to understand how best we should respond, but I was also leading the outbreak response team for influenza at that time in Abu Dhabi. Drawing from this, many lessons have been learned, and what is a unique and the strength point for UAE, based on my experience, is the long-term investment in the system and preparedness and response system that is not only focused in the health issue. It's not a health issue, but it's a whole of government issue. So one of the strengths that was done in UAE is establishment of National Crisis and Emergency Authority, NCEMA, which has different ministries, including Ministry of Environment, Climate Change, Ministry of Interior, and all other ministries that are, this is like a one government platform that is leading emergency preparedness, but the coordination is happening across different sectors which I see really one of the strength points that really showed the outcome of the investment during COVID pandemic after more than 10 years of strengthening such system. That is also very much linked into the long-term vision of the government when it comes to the well-being and being advanced in the technological part. The National Influenza Preparedness System was established as one component of the overall government preparedness and response, and as was led by the Ministry of Health, UAE, in support and coordination with other ministries. And again, I think the investments that happened was to establish and strengthening data systems, and I'm not talking here in terms of data systems into health only. And this is one of the, I think, distinct features when it comes to having a strong emergency and response system, is how your health system speaks to other and connect with other data systems that could support understanding, building AI platforms, and will help to address and analyze the different trends and support in the emergency response systems. In addition to that, I have witnessed many simulation exercises that happened for outbreak response, for other non-health emergencies as well, but there has been a big focus on responding, simulating the emergency response to outbreaks, known or unknown pathogens, and how the response overall, and then rating and identifying what are the points of weakness and how we can strengthen our system in the long run. This was also backed by the financial system and the overall legislative system for the government that really boosted the overall emergency response. So I would say that the distinct feature of UAE really was the long-term investment of the government in the preparedness and response system that is focusing on non-health, but also how does health emergencies arranged and coordinated with other also non-health entities, ministries of health and other ministries, coordination was an important factor. Taking you from the national response system, and I don't think that one national response system can really be successful if it was not interconnected with the overall global emergency response system. And here I will jump into I will wear the hat of the global experience that I had with understanding the influenza preparedness and response at the global level, and how it has major components when it comes to data, collaborative surveillance as one of the cornerstones. So we cannot really function as a strong global health system without ensuring that there is equity and access to data from different countries. So whatever is built as and institutionalized at a country level, it is also very important to not forget to be linked and shared somehow with the international community when it comes to data, because emergencies doesn't know borders, and we are all facing the same pandemic or the same threat because of people movement, because of the communications that are happening with goods and people across the world. So that the strengthening of the national response really is very much one component of the overall global health structure. And I have to highlight that currently the global structure for emergencies and response is under revamp, with the current discussions going on in terms of the global pandemic agreement that has been initially approved last year, but there are a lot of steps coming forward, including the innovation in the overall access and benefit sharing system, which is currently under discussion. But this is also a very important opportunity for countries to participate in the reform of the overall global health system. We all struggled during the COVID pandemic because of inequity in the distribution of vaccines. There are many lessons learned, and this is really the opportunity for the global health community to step on and participate actively in shaping of the global emergency and response systems to be more equitable and more accessible when it comes to data and information and samples as well. The third point that I would like to touch is about
Your Excellency. We're a bit short on time. Thank you so much for your intervention. Thank you so much. What you've shared shows how much strong national leadership can actually shape preparedness. But of course, for real impact, these efforts need to be aligned with the global strategies, as you have mentioned now. So Dr. Novello Sierra, from a global perspective, with the WHO's pandemic agreement and the PREP initiative, how are global preparedness frameworks being operationalized across the MENA region?
As mentioned before, I think several of the countries that are of the MENA region who are part of the 194 member states of WHO have joined the pandemic treaty. And the pandemic treaty, I think, establishes aspects of how to improve preparedness and how to go forward in actually taking the steps necessary for the preparedness for the next pandemic or the next emergency. Often, for example, I think that to put it more into the MENA region, what I have seen in several of the countries is that once we are in an emergency, we realize that the legal framework and the legislation to actually go forward with the countermeasures, as it was mentioned before, as Dr. Khan, is not there. So if you already, if the emergency already has hit, you're already too late. So I think that what the pandemic treaty has as a different aspect is that it's legal. It's not legally binding, but it commits the countries to improve the gaps. Specifically, it can be surveillance, it can be response, it can be preparedness, and there's not a one-size-fits-all type of approach, right? There are certain countries like our colleagues from UAE where they are quite advanced into putting AI, and we have working countries where there's no electricity for the cold chain to work. So it's a bit different in the approach. So you have to apply what works in each place. So for example, the PREP, which is a game on the word PREP in French, ready. The preparedness and resilience for emerging pathogens is a very clear number of steps and exercises and specific actions that each government can take to reinforce their preparedness to any respiratory pathogen. This time it was corona. But for example, we were expecting the next influenza pandemic for the past 30, 40 years. When H5N1 happened, we all thought that was the one, and everybody got very scared and all this thing. And then it ended up that it was influenza in the end. It was coronavirus, the latest pandemic that we had. So I think that this goes to show that having a revision first at the legal framework, but then you need to make sure that all the steps has been taken, as Dr. Antoine was saying. When you activate the emergency, all the systems are ready to go, and then suddenly, no, I cannot set samples for sequencing to another country because the legislation of the country prohibits that and then you start hitting these administrative layers. So I think that both the pandemic agreement and the PREP offer very practical steps in identifying what are the pathways to make sure that preparedness, contingency planning, and response are working together, and it will help your country or your region or your district to identify where are your gaps. And I think that it's gonna be really difficult to address 100% of what you want to address, correct? But at least I always like to put in emergency the things in 3 boxes: critical, urgent, and important. So we have to go in order, right? Let's address the critical first, then we move to the urgent, and then we go to the important. If you don't go in that sequence, you're probably going to find the midst of an outbreak is not the time to take care of the critical, that's for sure.
Thank you so much. Dr. Sarah, what we've heard reflects the bigger picture of how preparedness is coordinated globally. Now, let's zoom into the operational side, where action on the ground can make the difference before an emergency escalates. Mr. Elia, your work with IFRC focuses on anticipatory action. How can this approach be integrated into epidemic and pandemic preparedness frameworks?
Thank you. Again, thank you for having me here, and thank you for the Global Health Institute for organizing this panel. I would say that anticipatory action as a concept is rather new in the humanitarian world, one way or another, especially for us at IFRC, but it's really not a new concept when you look throughout civilizations and how they handled risks and hazard that they had to come face to face with and face throughout the years. It's really about shifting from a reactive response to emergencies to a more of a proactive risk management level of preparedness. And that includes embedding certain mechanisms that detect emerging risks before the outbreak escalates into a large scale health emergency that the existing systems cannot handle and cannot respond to. At IFRC, we are integrating anticipatory approaches by linking sort of epidemiological forecasting with community level action. And this happens through the forecast-based financing protocols we have and the early action protocols that we have, whose main job is really to define to define scientific triggers that are addressed through increased disease incidence, environmental changes like rainfall, temperatures, things that can affect certain outbreaks. And once these triggers are met or set in place, they activate early interventions. And these early interventions can range from prepositioning essential medical supplies to deploying mobile health unit, to awareness sessions for the communities in an effort to reduce the impact on the health systems and before these health systems are overwhelmed and not able to respond. Integration of these anticipatory approaches also requires some form of a cross-sectoral collaboration because the public health sector or the Ministry of Health cannot work alone and cannot respond to all these needs alone. And it's good that on the panel today with this discussion, there are people from the humanitarian world, and there's this collaboration between public health authorities and humanitarian partners that work on water and sanitation, that work on logistics, that work on nutrition, social protection. So it's a wide range of people that are available on the discussion and are presenting their findings or their gaps or their needs. Finally, I think anticipatory action in general should be institutionalized within the national preparedness and disaster risk management plans of every country, ensuring that the early actions and the interventions that we want to take are pre-funded and pre-agreed upon. Once they are activated, we're not going into debate over what we're going to do. We're already agreeing on these certain measures. This integration strengthens both epidemic readiness on one hand and broader community resilience. I'll just give a brief example. In several countries, IFRC and the national societies of said countries are working with ministries of health and WHO to link community epidemic and pandemic preparedness programs with early action frameworks. It's still definitely in some sort of pilot phases in certain area, but it ensures that we are ready and we anticipate certain risks before they happen and we are ready to intervene. Thank you.
Okay. I have no, I don't. Okay, great. I just have one question for Mr. Sherbil. Can you just give us just a quick example of how this anticipatory action has actually worked in Lebanon? Do you have like a small case study or a population or a pilot area that you have already seen this collaboration between the humanitarian, the ministries, and the government?
Sure. Sadly, it's not for Beirut or the example that I have for Lebanon. We actually have extensively worked with the Yemeni Red Crescent Society because we represent the MENA region. So Yemen is a country that has been afflicted with conflict for the past few years, and their health systems have been overwhelmed and reached the, the verge of collapse. So in an effort to anticipate heightened outbreaks, the Yemeni Red Crescent Society, with support by the IFRC, the ICRC, and partner national societies, were able to implement anticipatory WASH-based activities and WASH-based community preparedness interventions for around 100,000 people. And these interventions were definitely pre-agreed upon, and they included things like rehabilitating water points and sanitation system, pre-positioning hygiene kits for when we need to activate the protocols that we're working on, and conducting intensive community engagement and behavior change and awareness sessions.
All right, thank you so much, Herbert. Dr. Nada, you're here with us?
Yes, do you hear me?
Yes, we hear you loud and clear. Dr. Nada, from the national perspective, how is the Ministry of Health leveraging digital tools or AI to strengthen early detection and response? And two, what are the main challenges for sustaining these systems in the ministry or in Lebanon in general?
Thank you very much for your questions. So also thank you to invite me to attend to this panel. So let me highlight the importance of surveillance as information for action. So more we have better information, can have better decision for better health. So today we need to understand as MOPH and also as professionals what is artificial intelligence and to know how to integrate it within our work and in disease surveillance. Indeed, with the AI, we can have different tools and we can have improvement in different aspects. I will focus on 4 aspects. So I will go to general ideas and then I'll go to Lebanon experience. So the main 4 aspects that I want to highlight is about having better risk time surveillance, about having a better early detection of outbreaks, and also better diagnostic tools and classification tools, and better preparedness. And some of the talk before has also talked about preparedness. So for real-time surveillance, it's not only collecting data on timely manner, but also on analyzing the data in timely manner and sharing the data in timely manner. It's very important to do that. And here we have to focus that the AI tools can enhance real-time surveillance at global level. So to have better global health security, we can also have better real-time surveillance at national level, to have better disease control, and also to have at local level for better containment at that source, and also at the personal level to have better health promotion. The second aspect of AI is to ensure detection of outbreaks with timely investigation and timely response. And here with AI, because we have now to deal with a big high volume of data from various sources with various formats, so we need to know how to access this data and to handle this data. So we can detect signals, also we can perform advanced analysis, identify source of infection, and conduct risk assessment. The third aspect where we can use AI is to have better diagnostic of diseases and classification, how to diagnose diseases using imaging or lab testing, how to identify vectors like mosquitoes and other vectors like sandflies, and also characterize the pathogens, strains, and variants. And the last aspect is about better preparedness. With AI, we can do modeling, so we can have it for forecasting. Forecasting meaning to have better preparedness for the future and better resource allocation. So are the principles of how we want to use AI at the Memphis Republic has for the surveillance program. So what we are doing today at the ESU, so for the real-time surveillance, we want to explore the automatic coding. For some disease, we have to code before analyzing. For cancer or risky, for example, once that is collected, we have to code topography, morphology, behavior, and race, and then we have to do cleaning, and then we have to analyze, and then we have to do the report. So with AI, we can make some automatic coding with the large language model, and also do some cleaning to identify duplicates. And this is very good tools to be used in the future. For detection of outbreaks, we have started to use this application to reduce noise when we do screening every day on media to detect any signals about alerts. We have a lot of articles based on keywords, but we have a lot of articles that are not relevant. So we need to do noise reduction, and with machine learning like random forest, we are able to have good performance with the English articles, but we have to explore other tools how to do it with the Arabic articles. And also for the really outbreak detection, we can redefine our threshold for epidemic, because the ones that we have are based on historical data with the average and the 2SD, but with the AI, we can have other factors included for the threshold definition. As for the diagnostic classification tools, so our interest today is to apply it for vector surveillance. We have a threat in the world about vector-borne diseases and increase of the diseases like malaria, dengue, and others. So we have to prepare not only for the human health, but also as the ontological part. So we have to do surveillance for the vectors, to do mosquito surveillance. And the idea that we are doing, that we are working on, is to prepare a protocol, another protocol, where we collect mosquitoes, and with the AI, with the neural network, we can identify, we can have automatic identification of the mosquitoes. Either are these Culex or Aedes or others, so we can use AI to identify, to label the mosquitoes with their names. So we can do mapping of the vectors in Lebanon, and we can target what are the needed measures. As for preparedness, our work is to work on modeling of diseases, to do casting and forecasting for the future. And the new idea that we want also to explore is to try with virtual assistant to support human resources whenever we have a crisis. So with a large language model, we can have virtual assistant with reference documents that can be used, so we can have the answers at any time we want. So for me, there's a lot of opportunities with AI. And the main challenges is to know, to understand AI. We have to be trained to understand what AI can give for us and what applications we can use for that. It's very important to have this education of the people, of the staff, to know what AI, what is the advantages, and also to know what are the inconvenience of AI when dealing with ethical consideration. But surely, if well used, we will have better surveillance and better health. Thank you very much.
Thank you so much, Doctor. Just a small question from our side as well. Given Lebanon's limited resources and coordination challenges, is there something that you have learned and can share with us and other regional countries that have kind of similar situation that's going on in Lebanon? Can you share with us how you have overcome these restrictions when it comes to, yes?
With AI, what you do, you share the methods. You don't share the data. So, for example, we are using the epidemic intelligence from open source, the use for media scanning. And in the last workshop with a general workshop with other countries, we have demonstrated that we can use AI for reduction of the noise when using the EOS. So we can share the methods, but not the data. So, and usually when you go to the website, there's a lot of resources there. So we are happy to share the methods that we are using.
Yeah, I think that in surveillance, we basically have two types of surveillance: indicator-based surveillance and event-based surveillance. So, for example, what Dr. Nada was referring to, the epidemic intelligence from open sources, the EIOS, this is one of the tools where it is being used. Instead of having somebody just put a keyword, they go a bit further and establish certain thresholds, and then you can ask the tool to look for media reports or even social media posts about possible starts of a disease that can have epidemic or pandemic prone potential. So that is the challenge with that is that those systems need to be maintained on the long run. And like you said, the sustainability in low resource settings. How do you do that, for example, in areas where power is often cut, there's no internet access, for example, or usually, let's take, for example, the Ebola epidemic that we had. Most of the regions in Africa where the cases started, there was a serious delay of the information reaching the sources, and I think that this is also one of the reasons why it got out of control. So I think that the problem is that we don't have specific AI tools for health. We are triangulating or extrapolating what is being done now in terms of regular office work and all these things and productivity and so on. So I think that we need to have a stronger effort, like Dr. Nada was saying, maybe in the coding of diseases, maybe agreeing maybe on a common language for be used, so the information between countries is exchangeable, so you don't create a data set that is only being used in Lebanon and cannot be used in Jordan, in Egypt, and other places. So I think that a part of maybe the pandemic treaty, this is something that they can also try to work on, but I think that we need to have a common language. So the information, let's say, for example, Yemen had a terrible situation with cholera, for example. I think that if we have had any type of modeling from that, we could apply that to different regions and see the different attack rates, how it will affect, and it goes into your preparedness and response. But like I said, I don't think we have dedicated tools for health, and I think that probably that is the next step. Once we have them, they will not see how expensive it is to maintain them, or what kind of maintenance it needs to be done, so the tool remains not only sustainable, remains useful despite changing conditions.
So we're gonna go back to pillar 3, which is the cross-sectoral and regional collaboration. And as Her Excellency mentioned, unfortunately, most of the diseases cannot be contained in a geographic boundary. Most of the time, they are cross-boundary. So, Dr. Atiya, from the IOM perspective, what are the most effective strategies to strengthen cross-border surveillance and ensure mobile and displaced populations are included in preparedness systems?
Thank you so much, Dr. Rabah, for giving me this opportunity to be here with you and with esteemed colleagues in this panel, and to discuss this important topic about post-COVID preparedness, as I think COVID reminded us all about that outbreaks don't need or don't wait to have passport or protocols to move or visa, just to move with people. And also we have to be prepared, so preparedness should be moved as well. And from IOM perspective, mobility is not a risk, as some people may sometimes see mobility as a risk, but in IOM, mobility is not a risk. It is a continuous and ongoing activity, and we have to integrate this mobility into our public health system through many strategies. I will start by the first one is through both surveillance where movements occur. Preparedness begins in borders, in the peripheral parts, in corridors, and not only in the capital or the central areas. So we have to start from these points of entry, these borders. Under IOM health, we have a very important framework for health and mobility, health border and mobility management. It is HPMN framework. We embed this framework with syndromic surveillance, event-based surveillance at the points of entry, airport, crossing the lands, ports, and all the transit hubs. And after that, we link this data into our national e-warning system and our EBS system through the HR channels. So this step is very important that we if a signal is detected in one country, so before reaching being an outbreak, so it will reach the other country or the neighbor country, informing that there will be a risk of having an outbreak. So it's very important to put surveillance where movements occur. The second important step or strategy is to establish what I hear from other colleagues now about a very important word. It is coordination. And health and preparedness is not the health function only for the Ministry of Health or the people working on health. It is a multi-sectoral and multi-agency coordination process. So outbreak management starts by collaborating and coordinating with other ministries like health, interior, transport, and many other governmental sectors and also non-governmental sector as well. So we coordinate with each other to have a cross-border coordination committee and to have joint activity together, to have also, I heard from other colleagues now the importance of having practical activities like CEMICs, like tabletop, like many other activities that will improve our preparedness to face the outbreaks or the pandemics after that. And I will just mention or give a hint on our recent IOM WHO Africa CDC CEMICs it was in August this year with 4 countries in MENA, Egypt, Libya, and Sudan, and Tunisia. And it is very important to have an activity like that, like CEMICs, to prepare and to have to see the strengths and weak points, and to have a joint recommendation to improve our preparedness to face the future pandemics. The third and very important strategy I want to highlight is designing the surveillance system that focus not only on the disease or the pathogen or the data, but will focus on the people behind these signals, especially those people that are often missed or marginalized or mainly like the migrants or displaced population, seasonal workers. All these kinds of people are the most vulnerable sectors we are having in our countries. Either our countries are the origin countries or the transit countries or the host countries for these migrants. So these kinds of people, migrants, they are often the first affected sectors and also the least, unfortunately, the least visible ones. So integrate migrant-sensitive indicators into surveillance forms that we collect something about age, occupation, travel, route, and language needs, and link all these with surveillance and referral maps across all countries. It will be a very important step, and this step has many sub-steps under to have surveillance at the POEs, to have data on the movement, to ensure access and trust of these migrants, to have to have health assistance. Also integrate with the community and the community leaders and community institutes, and also to have the final feedback. So
Dr. Atia?
Sorry?
Dr.
Yes.
Atia, if you just want to wrap up, I just have one teeny question. What is one major barrier when it comes to data sharing when you're trying to work with migration-related surveillance? If you want to just name the most eminent one, the most important challenge or barrier.
Okay, without going into details for sake of time, so the most important, I will name about three or just names. The first one is like the political issue and sensitivity about data sharing. Also, fragmented system. We have fragmented system and formats. Countries don't have standardized format or data sharing between each other. They have different variants and definitions. Also, we are suffering from the capacity and the infrastructure gaps at the points of entry and also in countries. And the final one, or the last but not least, the having trust issue between each other inside the country, between the migrants and the government, and also between the country and the other country besides or the neighbor countries. So we have all these, and we have more and more.
Thank you so much.
They are the most important.
Thank you so much for your intervention, Doctor. Before we open the floor for questions, just a quick wrap-up, quick summary. AI and digital innovation are reshaping how we detect and respond, but only if paired with strong systems and trained human capacity. Governance and policy coherence are essential for sustainability beyond crises, and cross-sectoral collaboration from humanitarian to digital to migration is what will make preparedness people-centered. Now let's open the discussion for audience questions. If anyone has a question, please raise your hand or forever hold your silence. Okay, so if I would like to ask one more question for all of the panelists, if I may, what is the single most critical investment needed today to ensure sustainable preparedness in our region? So I think this is a big one. If we can start by who would like to answer first? Dr. Ngalo, please.
The single most important investment in preparedness, I would say, is human resources. Everything else you can buy. But if at the moment, for example, if you have a disease that requires, like COVID, IPC and ICU care and all these things, you cannot just make specialized staff appear out of nowhere. You can buy protection equipment, you can buy respirators, you can buy oxygens, but you cannot buy qualified staff at the snap of a finger. So I think that despite that we are talking all about AI and all these things, in the end we need human resources and human oversight.
Excellent. Your Excellency, Dr. Nada, Dr. Atiya, would you like to, Dr. Khan, would anyone like to answer this question?
If I may start?
Yes, please, Your Excellency.
I think this is really very important question, and from my point of view, I think the most critical investment is in a strong data-driven national system that links between early warning system to emergency response. We are talking about AI, but I think it's really about how much we can see so we can act. If we cannot see, if we don't have the data, we will not be able to act immediately to and predict emergencies and deal with it in a timely manner.
Thank you so much, Hanan. Dr. Nada?
Yes, so I agree with my colleagues, and also I think training people with the capacity with the health staff about the AI and the importance of the AI are really important. So we have to educate, we have to train ourselves and our team what is AI and what we want for it for our better health.
Perhaps I could just chime in as well. I'd really like to echo some of the comments of my fellow panelists. Without strong surveillance and intelligence systems, ultimately it's difficult to know how to respond. And we talked about anticipatory action, how to anticipate what is coming next. So I think those are going to be critical areas of investment in infrastructure. But I do want to come back to Dr. Sierra's point about human resources. I'm a practicing infectious disease physician, and I was on the front lines at the very beginning of the COVID-19 pandemic before there were vaccines or therapeutics readily available. And I do remember we had ICUs with ventilators and nobody there to operate them. And so, as you said, I think well put that investing in human resources is critical. Other things you can buy, but you can't just upskill people immediately. And the other resource you can't buy is time. And that's why I go back to the issue of intelligence systems. As time is kind of the enemy when you're dealing with an outbreak. The early signal, the early warning, the anticipation, these are critical to getting ahead of these threats and ultimately to supporting a coordinated action across the multiple different sectors and actors that are involved in the emergency response.
Thank you so much. Mr. Elia?
Briefly, I echo what the panelists have said as well, but I think the main thing that we can invest in would be coordination amongst the humanitarian actors and the public health sector. And I'm speaking from a humanitarian action point of view, and transitioning from these parallel systems to from working in silos to working together, conducting some sort of simulation exercise between different partners and different actors who are going to be responding in case of an emergency or in case of an outbreak. So I really think that we've seen a lot of gaps on coordination between different actors, and that might be worth looking into.
Anyone else wants to say something from the audience? Add something? Okay, yes?
Hello, everyone. Thank you so much for all the amazing presentations. Wissama Saili, I'm a physician at AUB MC. So my question is, since we have presenters from international organizations, private entities, and so on, everyone's saying AI and so on. What I want to ask is everyone working on their own proprietary AI? So everyone has their own model that they are training, or are there common services and products that everyone's sharing?
Do you mind if I maybe just start with the response there? Just sharing some perspectives.
Please go ahead.
Sorry.
Please go ahead,
I hope
Dr.
I didn't
Khan.
jump the queue there.
Please go ahead.
Okay. No, thank you for that question. I think, what is, there inevitably is duplication of effort. And I think this is something that really speaks to this broader issue of coordination and collaboration, because we have a finite amount of resources, we have a finite amount of time. Duplication of effort isn't necessarily getting us, I think, to where we need to be. I think the other approach that we've taken around information sharing is co-development with other partners, as we are co-solutioning on problems, so that we're not kind of developing something that's proprietary that can't be utilized in an external environment. Ultimately, building solutions together with other partners across many different sectors, geographies, audiences, and so forth, as a way to make sure that this knowledge is being embedded within other organizations, so that they have this kind of ability to increase their capacity and their understanding and knowledge. So just a couple of comments. I'm mindful of time, so I'll wrap up there.
Thank you so much, Dr. Khan. Dr. Farida?
Thank you. I would like to add to Dr. Khan that I agree that there are some silo work happening at countries level, but from the Global Institute for Disease Elimination, we are also trying to support some of the regional collaboration efforts. We are working closely. For an example, as with WHO EMRO team, to build a platform for malaria data in the region for the last 20 years. We believe that such collaborative work, where countries can share their entomological data and geospatial data and the changes that happen over 20 years, could be an asset where other countries can utilize in building tools that could help to forecast and assess the risk at each country at the national level. So I think we need more of such example of regional collaboration and support because a lot of data does not speak to each other. We have silos at country levels, but we need to ensure there is a collaborative approach, a teamwork to support some of the regional priorities, whether it comes to collaborative surveillance or when it comes to regional emergency response and preparedness systems.
Thank you so much, Dr. Farida. I think we've come to the end of our panel. Thank you so much, our esteemed panelists, for your very, very, very valuable insights. I think I can leave the floor to you.
Thank you, Dr. Ziadeh, and thank you to all our distinguished speakers for your invaluable contributions. Thank you all for your participation, engagement, and commitment to strengthening pandemic and epidemic preparedness in the MENA region. This brings today's event to its end. Please join us for lunch and enjoy this opportunity to network with fellow attendees. Thank you so much.